Bless you, my child.
Yeah.
Okay, last week I sent, at least to some people, some information. Some of the written emails were not something I could read, so I regret. And I actually brought one paper copy that I can leave with Joan in case somebody wants it. If I do not make you uncomfortable today, I'm not doing my job. We're talking about end of life. For the most part, this occurs under other circumstances also. But it means that you are sick enough that there is some question about your longevity. The most frequent cause of limited longevity is your birthdays. So the answer to that is recognize and enjoy the preciousness of each moment. And that's my meditation each day. Precious is not based upon rarity, it's based upon fragility. And as a physician, I've seen all the caca that can go on with regards to people's wishes. And that's why I call this repealing Murphy's Law, because things do go wrong. And my role here today is to equip you, empower you to take precautionary measures so that at least you get what you want. Has anybody, do you have an advance directive? When's the last time you looked at your advance directives?
This morning.
This morning?
This morning.
Okay.
This morning?
This morning?
Well, it's been a while since we looked at it.
Yeah.
Things change. And how to write an enduring directive is tricky. The New York Times guest essay, when faced with death, people often change their minds. And I sent this out. Did you get?
Yeah.
Oh, so I need your legible email.
Okay.
And this had to do with a woman who was very adamant that she did not wish intubation. For whatever the historical reasons that she chose this, it was very, very clear. And she came into the emergency room with pneumonia. And they treated her conservatively, and she wasn't getting better. So they had to make a choice, along with the family there, what to do. Do you obey the advance directive? Or do you, I'll use an interesting word, make an appropriate response? There's an old Zen story about the young monk who goes to the older monk and says, "Oh, you are so wise. You always seem to know what to do, and I'm so confused. Can you give me any kind of advice?" Always make an appropriate response. I've found that the most enduring decision is based on my values. So that the way that I wrote my advance directive was based upon my values. And I mentioned that my wife also wrote hers and chose something different than mine. But mine had to do with my ability to be present and self-aware and to be loving and to receive love. So I could do that if I were a quadriplegic. Not a choice I would prefer, but if so, it meets my enduring values. Have you ever considered what your enduring values are? I've already given you an A on your test.
Don't be a vegetable.
And so a vegetable is what? Besides salad?
You're acting like a carrot laying on the table. You don't know what's going on, but you may still be alive. But
So
you don't know what's going on.
So it's not brain dead,
Mm-hmm.
but you have life support, maintaining at least your breathing, and possibly medicines to maintain heartbeat.
Mm-hmm.
So that's a bright line that you don't want to cross.
Well, I don't want the continuation of that life, that type of life. If it's necessary for a brief period of time to get me beyond it, where I'm back more
I mean,
normal.
on life support,
Yeah.
to say that you're, quote,
Mhm.
a vegetable, not a vegetarian, but a vegetable,
Yeah.
that implies a long duration.
Yeah.
So you're talking about life support qua life support,
Mhm.
intubation, possible CPR, where they do paddles and restart your heart, or things, or medicines. How long a test period of, let's say you come in with pneumonia and you need intubation to recover from the pneumonia, but that's always uncertain. That is the best practice many times, but it is by no means inevitable that it'll work.
Mhm.
So how long a test period would you want the doctors to observe?
I think our directive says a week, but, if there's a chance of improving, then your agent could change that,
So you have some flexibility in that.
yes.
Many times, a week will define the future course, but by no means all the time. And there's certain specific things like a stroke that has rehabilitation potential, or head injuries, which can be difficult to assess the future. I put down 2 weeks because I know that, one, if I'm on such life support, I'm probably not so aware that it's bothering me. And the disagreeableness is looking to an unspecified future time on this same condition.
I've heard these horror stories about people, once they're on life support, they can't ever, their agent can't make the decision.
Karen and Quinlan.
Yeah. Well, that was a dispute, wasn't it?
Yeah.
And so I'm going to go over ways to avoid disputes. One, in your advance directive, specify that you can have a limited test period. And that what I wrote it may take some time to determine that this and life support may be initiated. If it is the opinion of at least 2 physicians, including a neurologist, and you will have this document,
Yeah.
that the chances of my recovery to a satisfactory state are less than 5%, life support may be withdrawn.
It seems like a very low percentage to me.
Statistical significance. And I'm sure all of you have gotten A's in your statistics class half a century ago. That is, quote, the p-value, which means that there is a 95% chance that the decision is correct. So if it's less than 5%, then no. But since there is uncertainty, there's a reasonableness to extending it to the point where you've got 2 physicians, one of whom is a neurologist, saying, yeah, it's less than 5% chance you're going to get back to the state that you were before. Anybody know Latin? The status quo ante, the state before this happened.
Why do you choose a neurologist specifically?
Why do I? Because neurologists have a lot of experience in dealing with people whose brain has been damaged in some fashion. So they have the most experience.
Okay.
If you have a primary physician who knows you and knows your values, and knows your values because you've written them down, then that should be the other person. But, you know, we don't always get real sick from cancer, where there is a slope of decline. Progression of a chronic disease such as malignancy, heart failure, so that I'm unable to communicate, and that state is not likely to change, and death is likely to occur within 6 months. I don't need to go on from that. So there's the contingencies that you write into what makes sense to you. And I hope you're a little bit uncomfortable because you're really thinking about, oh, feces. This is going to be something that I have to deal with.
Now, what's the deal with the 6 months? Because I've been with 2 individuals who got cancer and they survived for 6 months, but some of that 6 months was pretty good. So I didn't quite get what the 6 months.
This is under the circumstances that my state does not change.
Oh, you stay in bed.
So that I am, by the hospice definition of terminal is life expectancy less than 6 months. So that's an arbitrary number, but it's standard. Development of dementia.
Yeah, that's what.
I think for people our age, that's probably the most feared disease. Well, what about that? Dementia, first of all, there's many different kinds of it. and they have different outcomes and different symptoms. But we'll take the most common one, which is Alzheimer's disease. And everyone has heard about the person that just doesn't know anybody. How many do you actually know personally? I mean, have you had personal contact with someone who has dementia and doesn't know who you are, even though you're a long-term friend, and seems happy? Sometimes, even given the state of the world today, maybe it's not so bad not being able to recognize all the stuff that's going on.
My mother had Alzheimer's, died, and at one point, my sister essentially told me, "Don't call her on the phone. Don't call her on the phone, because when you do that, she doesn't know who it is. She gets all confused, and it really isn't doing her any good." So consequently, I understand that. And so I stopped calling. Initially I thought it was
Did you
pretty,
continue to visit?
well,
She's in Iowa.
it was Iowa and we were here, so it wasn't very often.
Was this before Zoom?
Yes.
So the technology now has allowed at least visual contact. And our brains are literally wired for visual information. So whether that is satisfactory, you would know if you tried that. And it would be as if that person saw you on television.
So,
So what can go wrong? That's one of those lines it's in movies where you know something's going to go wrong. And I can't really tell you what will go wrong, but I can tell you that the chances of something are high. So here are the things that you really need to know for proactive. One, the directive is not legal. In this state, you do not need a notary. You just need 2 witnesses. And the advance directive is as simple as I specify X to make decisions for me if I cannot myself. And I mean, giving the people who read it a chance to look at it and know where that person is probably a very good idea. But that is an advanced directive. You don't need a fancy form. The fancy forms, and I used 5 wishes, which is available online. I think you have to pay a little bit for it, $15 or something. 25 inflation. And the state of California has a free one, and there are many other forms. But the essence of an advance directive is say, I want this person to make decisions for me if I can't. And so the scenario is the sirens are, when the ambulance are finally coming to a close as you get wheeled in on a gurney to the emergency room. Oh, where's your advance directive? Oh, it's in my safe deposit box. Well, it's keeping it nice and safe there, isn't it? So how do you maintain a copy of your safe deposit, of your advance directive? Anyone here who does not have a smartphone? No flip phones? Oh my goodness gracious, we have a digitally advanced audience. So you can put a copy on your smartphone. I also recommend, since thumb drives, USB drives, even if it's now USB-C, are the size of my thumbnail. So that can be kept on your keychain. And what is the first thing that, if you go to the emergency room, people ask?
Where's your insurance card?
Yes! So you put a note on your insurance card where your advance directive is.
Oh, that's a good idea.
So that's straightforward. So it is going to be where it needs to be. Available to the people who will be making decisions on the spot.
And we have this little envelope on the side of our refrigerator that has all our medications. Should we put the advance directive in there as well?
Why is it on the refrigerator?
Well, because that's where emergency people look for stuff.
And would it be useful for the emergency people to see your advance directive if they make a house call?
I would think so.
Nod your head like this. So, yes. There is another document called a POST, Physician Orders for Life-Sustaining Treatment. Some physicians will make you fill this out, or ask you to fill it out, to take the burden off them and off you, because it's a doctor's orders that is legal most of the time. Guess when it isn't observable, or excuse me, observed? When you're in some other hospital, or you're in Detroit. So the POST is not a fail-safe, and is really appropriate if you have some progressive, likely short duration of living. So it's overused in ways it was not intended. Yes.
We're members of Kaiser.
Yes.
And our advance directive is located in their
their
hospital
system,
on
yeah.
their system.
Yes.
Is that, would that be accessible, or would we need it in, like?
Do you have access to your medical record there yourself? Yes, you do.
I do,
Yeah.
okay.
I've got a thumb drive with that.
Have you looked in your medical record to see if it's there?
No,
When I gave my,
we had one and then we updated it, so just hoping.
when I gave my advance directive to the hospital, 2 weeks later, I checked to make sure that it was available. So it's filed under God Bless the Child Who Has Her Own, or his own.
Okay. They did, when I was hospitalized, they said, I see you have an advance directive here. They didn't bring it up and say, oh yes, we'll do this or we don't do that, to my knowledge.
Sometime, particularly if you have a primary care, which you often do it with Kaiser, ask that doctor to read it.
Did you see my second question then?
The answer to your question is, this is correct. That the Kaiser doctors get a copy of everything.
But not until I was released.
That's a copy, no, that's a copy of what happened during that admission.
Right, but when I asked them, I haven't heard anything from my primary doctor, they said, oh, she'll get all the records when you're released.
The records of that current hospital stay,
Okay, so,
not the advance directive that you put in,
so my
decade
primary
ago.
doctor should have known that I was hospitalized. I never heard a word.
I don't know how forceful that hint is to the primary doctors. So I can't answer that
I'll
question.
just have to check it out, see. Cause I was surprised that the primary doctor hadn't contacted me at all.
Were you seeing another doctor?
I went into the ER.
Oh, okay, cause I'm a Kaiser member too, and if you're advanced to a specialist or somebody else, a lot of times the primary care doctor doesn't know.
That's why, who should know about your wishes? Anybody?
Both.
Yeah.
The mailman?
No.
If it's some reason,
If you mail
where
it
to
yourself.
deliver the mail, I am, but not probably not.
So just nominate people who should know what your advance.
You know, not only your spouse, your children, your doctor, I mean, I think.
Spouse,
people
children, doctors,
Hospital.
hospital,
Neighbor?
neighbor possibly, if you have
Close
a good neighbor, and
relationship.
that's not an insurance company.
No. Yes. You sound like an ad now.
Well,
It's
anyone whose actions, who will take some kind of action based on knowledge of where you are, would be somebody to send it to.
And or somebody who would be considered authoritative and respected. They live in the parsonage, well, at least one of them lives in the parsonage just down the street, clergy. Particularly if this is an active part of your life. So let's say, as I have 4 children, and one of them lives in Anchorage. The other 3 live right around here. In fact, one of them lives upstairs until 2 weeks from now. They bought their own house.
Good for them.
You're not evicting.
No. I assure you that we will continue to do childcare and change diapers and all of that. People can challenge your wishes. Oh, nobody mentioned the most important person.
You.
Me?
Not me.
You're not able to speak.
Oh, I'm not.
What is the name of X on your advance directive? The person who will speak for you.
Mhm.
So, do you need a conversation with that person?
Yes.
You bet your bippy. And my spouse, each of us nominated the other person, and also nominated our twin daughters. When I told them about this, they said, "Dad, you've told us the same thing so many times, we got it." So I have very good communication with members of my family. But let's say that daughter who lives in Anchorage is kind of estranged, which she's not. And you're in the hospital, you've been on life support for 5 days, the outcome is not clear. She's been called, I'll say it's the daughter. She's been called and comes into the emergency room just as there's a code going on. And what does she say?
Save him.
Save him! You've got to save him! Does the loudest voice in the room take precedence?
Often.
Too often.
Too often. So that's why having a document visible to the medical staff is so important. It trumps a screen. So that's,
In the case of your daughter, would that be somebody to have as on the advanced directory or not? Just as a, it seems like if somebody's difficult to reach, it's not necessarily somebody should be on there.
the most important person is the one you name as surrogate. So other people do not have to be local. The question is there anyone in the family who might object to what your wishes are? And I've seen that happen.
Sometimes you can't know that until the circumstance either.
Correct. And I'm also on the ethics committee at the hospital. The case was that of a father, older, who was really terminal. And the son insisted on continued treatment, no matter what we said. So I think the word is intractable. And ultimately, we were able to take it to the ethics committee, and that allowed us to, according to hospital rules, we are not obligated to provide non-beneficial treatment. Turns out that the reason the son wanted the father to stay alive is that otherwise he would have to take over all of the family business, and he did not feel equipped to do this, to have this burden on him. So there are many, many hidden issues that don't appear at all until the crisis.
Logic doesn't necessarily play a part of all that. Because in the case of the son, who was running it when the father was
As
out?
long as the father was alive, he was responsible for the family business,
But
even if he was sick.
Sick or out of it cold. Yeah.
So it's a little bit like
You can't sue
one of
me.
the when a president is having surgery and is under anesthesia, the vice president
Steps forward.
has to be willing to step up. So there are circumstances where that occurs. Did you ever hear about the elephant in the room?
Understood.
No, because nobody talks about it. So when I started my oncology practice in 1978, when I started practice here, nobody talked the big C. Nobody talked about that. And now it's gone down the alphabet one click, and nobody talks about the big D. And that is not depression. That's dying or death. I wrote a published article about, it was titled, "Death Isn't the Problem. Now dying, that's the problem."
When you're dead, you don't have any more problems.
There are certain ecclesiastical groups that may argue that, but I don't think so right here. So what about the aspect of dying? The process of being, I'll use the word ill, sudden death does not include the experience of dying. But given our medical system, how fractured it is, it does do one thing really well, is keep people alive and extend their life. So what are the things that you really don't want while you're, and I'll use the word terminal, like there's the train terminal, so that the train is on the track, but it's still some miles away. But you need stuff. What are the kinds of stuff that you don't want?
A lot of pain.
Pain. What kind of pain?
Very terrible pain.
Terrible pain, like hurt, like broken arm or broken leg.
Yeah.
What about emotional pain? What about spiritual pain?
Confusion.
Confusion. How confused?
Well, me or confusion among a medical team as to what to do.
Yes, I absolutely agree that you do not want a confused medical team. Uncertain is not confused. And again, that comes up where a person's had a stroke and the prognosis is not clear yet, particularly in the first few days. They're not confused, they just know that it takes time.
What can the body do for itself first?
Correct. Well, the body is doing for itself all the things that the medical system is giving it. Oxygen, intravenous fluids, sometimes intravenous feeding. A balanced amino acid, lipid, and electrolyte solution, supplying at least 1,500 calories per day, sometimes more. Is there any problem with that? I mean, you've already got the IV. Yes, there's a problem because there's infection.
Here's what infection.
Infections can occur. And so having nutrition through your digestive tract is preferable. Well, how do they get there?
It's a port of some sort.
Intubation.
This is the port opening right here. So there would be a tube going down through your nose into your esophagus and then into your stomach. Is that the right thing to do?
If the prognosis is that you're gonna get better, maybe.
If there is a chance of recovery and it's temporary, you bet. Right on, right on.
Okay.
Usually communication stops. Can you talk when you're at that?
Yeah,
You can.
the talking goes through your voice box, your larynx. That is not where you want food to go. So they are near each other but not communicating. So the problem with that kind of alimentary feeding is, anybody? Aspiration. So it's not without a downside. Everybody knows the concept of cost-benefit analysis. That is variable depending on how much you want the benefit and how likely the benefit to be. So I said that the benefit has to be greater than 5%. That's a low number. I like it here. So the benefit, when it's temporary, to allow you to recover. I had a friend who had lots of complications from treatment of esophageal cancer. And part of the complications were holes. Holes in her esophagus, holes in her respiratory system, trachea. Now these were teensy holes, but how big does a hole have to be to have a bacteria go through it? Microns. So, and she did have complications because of these holes. And she's recovered. Back pretty close, aside from the memories, to the life that she had before. Does anybody remember playing checkers? Did you move your pieces out of the back row?
Yeah.
Sometimes.
Well, there's some people who don't. Because if you move your piece out of the back row, your opponent can get kinged. Or politically correct, queened. So that's a way of assessing people's risk tolerance. I had a patient who had a semi-benign brain tumor, and it was treated. She was a young woman in her early 30s, professional. And in our follow-up visit, she talked about whether she should have a child. And I left her with, it isn't exactly a koan, but it was a challenging question. Do you play to win, or do you play not to lose? And that, dear friends, is the question. Is it your personal style to risk something for something that you really want? Well, it depends on what the downside is. Job had a pretty big downside. And if you had to sacrifice your entire family in order to live, not so much.
Trump would.
Easy. But he can't do that while he's in jail. Well, I suppose he could. I'm sure somebody would be happy. to help. So this is real stuff that we're talking about. And that's why it takes knowing whether you play to win. In this case, playing to win, to have your values observed by the medical system as much as possible. Oh, by the way, if you have surgery and you have an advance directive stating no intubation, you sign that away so that they can have an anesthesia to do the surgery. Well, how long is that operable? No play on words. Until when you're out of the recovery room, when you're back in your regular hospital bed. It used to be that at least some surgeons who are nameless would not cancel that, removing the advance directive, until you were discharged from the hospital. That's not kosher.
What's the point?
So, under the circumstance where you have surgery and you have a very discreet advance directive that you do not, I mean, this could be surgery to remove a brain tumor that would leave you, if not a vegetarian, then kind of vegetable-like. So, you want to know that the advance directive will be canceled at least within a short time. That's one of the things that nobody really knows about. That's one of the dirty secrets of medicine.
So how do you do that? You just tell them or have them write it down?
You ask how long the resuscitate order
Correct.
is going to last.
Okay.
And then you just ask that doctor.
Okay.
Is that the main thing that would be relaxed? Is there any other thing you do? Other than resuscitation, that would have to be relaxed.
No,
No,
Um,
that's the one issue.
that's we're talking about life support,
Yeah,
and so that would be the
feeding tube probably wouldn't be the issue.
no.
No.
And did I answer the question about feeding?
Pretty much.
Oh, by the way, they don't always have to do a tube through your nose. They can cut a little opening directly into your stomach, and that does not eliminate the risk of aspiration, but it sure makes your nose a lot more comfortable.
But does that have a chance of infection as much as an IV?
No,
Really?
no, there's much less chance of infection. We can get a little bit of soreness around it, but that is treated with like some topical ointments. I hope this whole series has been useful. You mentioned that it was useful.
I have a question because I'm concerned. I saw my father go through frontal lobe dementia.
That's ugly.
And is there any way to invoke the death with dignity before you are in that state?
If you are certified by 2 physicians that your life expectancy is less than 6 months, then yes. That is true in California, Oregon, and Washington State.
So would you write that in the advance directive? Or how would,
You could. There may be specific illnesses in your family that ALS, Lou Gehrig's disease, that if that is a hereditary risk, long before you reach at least my number of birthdays, you may, again, set your values on record that what it is that is that bright line that if this happens, no way.
is that what you would call it, or how could you verbalize that in your directive?
If I had advanced ALS and was unable to care for myself, then I would not wish life support. If that's the
Yeah, because you didn't need life support.
Oh,
per se.
I wish if I meet criteria to avail myself of aid in dying.
Aid in dying.
I think that that's pretty clear.
Of course,
And you need 2 doctors to verify that.
right. I think it's harder on the family than it is on the individual.
So my wife's advance directive said that she's willing to stay alive as long as her daughters want her to. So the decision about how long she lives and under what circumstances has been given to our daughters.
But she's talked to them so that they have a good idea of
Yes,
what you would want.
yes. And she has amended her advance directive to put in the conditions for removing life support.
I didn't get that.
In her advance directive, she has put, as I did, if there is no chance of returning to a life that I consider worth living, life support can stop at X, Y, Z.
Right.
So if you don't have the advance directive there when you hit the emergency room, they may, because they don't know all the things that are going on until they get to see that, they may intubate. But those are the circumstances where you're probably not very cognizant in any event.
Right.
So that gives, like be an hour or a half hour before it's clarified. And then
I
that,
question the idea of putting it on your cell phone. Because,
They take it away.
yeah, how are they gonna get to it?
well, you have your cell phone with you when you come to the hospital.
But they throw it in the bag and hide it.
No. You say, or have somebody say, her advance directive is on her cell phone.
Where?
And so that only occurs, the bagging your shirt and your shoes and so forth, after you've been in the emergency room for a while.
Isn't there a little heart on your phone that is accessible for your health and your medications and so
How do they
on?
get into
It can
the
just be,
password?
right,
This is assuming you're
Doesn't it go
lucid when you
past
go in there.
Well, you may want somebody with you to tell them how to get in, and that little thumb drive doesn't have a password on it.
Right. You need some new limb drives.
If you go in by ambulance, your advocate would not necessarily be with you.
Correct.
They usually follow along, don't they?
Though I certainly have seen the advocate in the ambulance coming in the driveway. And the ambulance is not gonna be doing, an 80-mile-an-hour drive, so.
Yeah.
You're gonna have time to get in your own car. Will they automatically take you to the hospital that you prefer?
No.
This is particularly true for trauma. Well, I have really been honored by being able to speak with you. I hope the things that I say make your life better.
Bill, I'm really sorry that I wasn't able to get to your first two talks.
They were recorded, as is this one.
Oh, okay, good.
There was one question. What we have are lawyer-written mass directives. You know how those go. Now, if we want make an addition, like you've got here, can that be added easily and have it be attached, or be attachment?
Yes, that's exactly what I did. Because lawyers, guess what, think like lawyers.
Mhm. So would the lawyer have to do the attachment, or you?
You write your attachment, you sign it, have it witnessed, and say, I want this to be incorporated in my advanced directive for healthcare. You may want to say, and this should be observed in preference to anything else. So that's what I did.
But you didn't need to go back to the lawyer to get it.
Oh, we were doing that for trust.
Yeah.
So,
You know, our attorney said that you can be so specific in your advance directive that if you want classical music in the order of Mozart, Bach, or whatever, played while you are dying, they have to adopt.
oh yes. The 5 Wishes has space for, and prompts for all of the different things.
They do.
I figure that if my family doesn't know what I want, the music isn't gonna make a whole lot of difference. Though I did specify the music I wanted played at my service.
Okay.
Thank you very much.
Oh, you're welcome very much.
No,